It's a great pleasure to have you, Dr. Montana. You are known as a part of the political economy in the field of social inequalities in health and health equalities. As you know that we are taking this interview for a series of democracy for a US-based NGO. And we are starting with your interview, and we know that you have a great work around this area. So can you please tell us about your trajectory coming from Barcelona? How did you end up as a professor at the University of Toronto?
Well, to start, I guess the context of Barcelona in the years I grew up led to an interest in social inequalities because I grew up in the middle of a fascist dictatorship, Franco's, and my family had been on the losing side of the fascist coup that occurred in the 30s. And this regime, was responsible for a substantial repression in my family. For example, my grandmother's legal tutor, the person who took care of her financially, had to leave the country. Leaving her was a minister of justice for the government that had declared Catalan independence. And she was impoverished as a consequence. She was left alone. They stole her money. So there was a strong consciousness of anti-fascism and anti-authoritarianism. Also, my mother was a lifelong anti-fascist activist, you could say left activist, and she was tortured by the police. She was detained, spent nights in the famous Via Laietana detention center, and then she became a lifelong cooperativist and went Latin America to work as a teaching women how to run cooperatives, and also in many different egalitarian causes, from these ones to anti-racism, etc. And being a cooperativist, that was a big influence. My uncle was an anarchist. I remember him coming bloody from being beat up by the fascists. And even one of my grandfathers during the war had been an anarchist in the collectivized year in 1937. Well, some of it I didn't know at all until because they tried to protect me, so they didn't tell me. But that influenced a lot my interest in social inequities, and that there was no, I would say, a school of public health, and that so it was necessary to go abroad. And by then there was a famous professor, Vicente Navarro, who had established himself at the Johns Hopkins School of Public Health, had read his books. So that was the logical place to go. Plus the situation of Spaniards and still and Catalans, in my case, as in Europe, was that there was quite a bit of discrimination. Right? There is this, I would say, hierarchy of countries. So compared to the Nordic countries and to the European countries, the Latin countries are considered to be, say, not so European and not so important, and so it made in the United States, being a country of immigrants and with strong public health schools and with that professor from the place where I came from,
Okay.
it makes sense to try to study public health there. So
Okay.
that's what I did.
Okay.
And then once there, I started working with unions and women unions led by women. And these were the Appalachian nurses and nurse assistants. So I studied first. I got the system in the US is that you apply for grants and then so my links to conduct primary data collection were with unions, in particular the SEIU,
Okay.
Service Employee International Union,
Yeah.
and the workers that first I thought they were the mining workers that would need more research, but as I entered the scene in the research scene in Appalachia, I discovered that many of the jobs had become more middle class, and that there was a lot of local ambivalence with regard to production. They were more interested just in SCS and at most some studies with this and SCS. So I thought that actually social inequalities and class were dealt more directly and had a better chance to be useful in the field of occupational health inequities. So I gravitated with that into the healthcare sector. I knew best, and these gendered unions and nursing jobs and nurse assistants in nursing homes, which I discovered were the satanic mills or the Dickensian version of the 21st century in terms of employment and working conditions. At the same time, I was trying to bring a lens of class inequality into occupational health and models that were popular then, so-called demand control, Karasek type, from a critique that view working conditions as the consequence of employment relations and employment conditions. So that took a while, but with my colleague Joan Benac from UPF, we developed a kind of a field of research that now it's called precarious employment, and that merged the ideas of became would say entrenched in this field, and my contact with nursing started from this research. Then, as the issue of coming to Toronto was motivated, difficult to would say live in the US, mostly raise kids there. So so it was I took actually a pay cut and ended up in Toronto, in Canada, where there is a universal healthcare, as you know. Educational system is moderately egalitarian. And I would say that had to be a little bit with the political climate of the war in Iraq. So that and other issues that are professional, etc. Right. So this is the I would say, in a nutshell,
Okay.
an answer to
Okay,
the question.
thank you. Thank you very much, Dr. Montana. Now you will change the gear and then we will ask some questions regarding this series. So what is your opinion about this contemporary political economy in Europe, and then how it affects the current COVID conditions, and then what are the solutions in your opinion?
Well, I first, the political economy of health school, which I would say, like the research mentioned before on precarious employment, on
Mm-hmm.
social class proper,
Yeah.
and health that I developed with my colleagues from Barcelona, originates in great part from the students and um, co-workers of the previous generation that were led by Professor Navarro, I would say, from Hopkins.
Okay.
And there was also, I would say, Leslie Doyle. She's from Bristol. I used to work there, as I know. Another researcher from the UK in public health, coming from public health.
Okay.
I would say in my generation, we moved these ideas that were in the policy
Okay.
arena and policy analysis into
Mm-hmm.
empirical epidemiologic research.
Okay.
So I think that it was Claire Bambra that coined that term to
Mm-hmm.
refer to our group. It's there
Mm-hmm.
is an interesting recent paper by Kate Smith where
Okay.
she did an empirical analysis of the clusters of researchers in the field of social inequalities in health.
Okay.
And this kind of Barcelona group
Mm-hmm.
appears separated on the
Mm-hmm.
left side,
Mm-hmm.
very distinguished from the US disparities group and from other epidemiologic groups in Europe. I would say the groups doing gradient type research,
Okay. Okay.
and that tells the story. So what I'm saying is kind of empirically based. So
Mm-hmm.
the political economy of health have survived at least two, maybe three generations. Its
Mm-hmm.
roots, of course, come from Engels' a study on the working class in Britain.
Okay. Okay.
And but it's, I would say, one of the contending approaches into the field of social epidemiology
Mm-hmm.
by making more emphasis on political, economic, and ideological factors that
Mm-hmm.
other researchers, for example, I would say the gradient approach, which is associated with the work
Mm-hmm.
of Michael Marmot and
Mm-hmm.
Whitehall, is very mm, empiricist and pragmatic in the
Okay.
sense that the field is dominated by associations, by
Mm-hmm.
correlations, and there is less emphasis on explanation.
Mm-hmm.
Definitely not through uh, employment relations or um, class relations, which is what
Mm-hmm.
the political economy approach
Mm-hmm.
does. In There are exceptions on both sides of the Atlantic. There's been quite a bit of research since the group of David Stockler emerged, and others in the US on the effects of economic downturns
Mm-hmm.
on health. I was not, we and I were not involved with this research because we didn't see it a very uh, uh, immediate application into the problems of health inequities, like
Okay.
public health prevention. You're supposed to do it only when there is an upturn and then not a downturn. It didn't seem to be a type of research that had a strong translation into the problems of public health. So the political economy of health in general tends to be more policy linked, in the sense that the idea is to find analyses that lead to policies that can be implemented and evaluated. And that has been a strong fight in the field, because most of social epidemiology, health equity, global health is descriptive. And we see that even with the COVID, no, we need more data.
Yeah, definitely. Yeah.
We need more data, more disparities, and more comparisons.
Indicators
between,
and
and very little in terms of solutions. So a little bit, the idea would be to provide an alternative to these views. Budgets, for example, in my native Catalonia, some departments of health that have research centers, they have been spending years and years doing cranking paper after paper as if they were research institutes to note disparities between neighborhoods and better estimation of small areas, while there's relatively very little in terms of health promotion, prevention, policies that could be implemented and evaluated. So much so that you may know that like France or Italy, Spain, Catalonia, Madrid in particular, have shown one of the worst managements of COVID. And in part is because lack of preparation. And lack of preparation means that there were not the manpower, the expertise to be ready to do the case identification, tracing, and other activities recommended just 2 years ago by WHO to face the possible public health emergency brought up by new epidemics of infectious disease. So we're facing these
challenges,
exactly. No public health schools, an emphasis that's mostly, even the critics of these positions still are MDs who are clinical epidemiologists who are asking for more epidemiologists. And so there is a big gap in the way of thinking on health inequities, I believe, between purely descriptive association framework to one that favors understanding and policy translation and policy implementation and evaluation. And I'm seeing the same problems as we speak that are not corrected. So in my country of origin is particularly bad because the structures are very hierarchical and rigid, and they originate from the Franco regime. Even 40 years later, some of the employment, civil certain structures remain the same, and the culture is one of ownership of civil servant positions, not so much of service, I would say. And technical positions are really de facto positions that are very politicized and not they are done to persons who are very close politically to who holds power. And of course, that's not the best recipe for handling a public health emergency. So, and as I said before, the public health arena is dominated by MDs. Now, even MDs epidemiologists, but still have a clinical perspective. Therefore, for example, they don't see the COVID as a syndemic, they see it as something that should be controlled by looking at the R, the index of
magnitude. Yeah.
So start, stop, you know. No problem that since the 60s, it has been acknowledged that that the economic support is part of the public health management on epidemic, but that doesn't enter into, I would say, the current considerations. So the political economy lens, in my view, within health equities, inequities, allows for this slightly different approach than the classical social epi, I would say, classical, I would call the white hole type. Intellectually too is, in my case, is not very stimulating. I think it's not a surprise that one of the most productive researchers, British style, right? That is a very pyramidal system where the professors have a lot of clout and have a huge amount of papers and so on. Didn't like this field. They moved to one that was more explanatory, more challenging intellectually. For example, in the case of, I was thinking of George W. Smith, a British professor, who abandoned completely this type of social epidemiology and went into basically genetics. I'm not surprised because how much can you do showing these gaps over and over again? And I mean, without providing explanations, just with associations between occupation, income, and education. The field of stress has more than 1,000 scales, but apparently in social epidemiology, there only can be 3. And God forbid that one tries to explain something with them, because in the sense of introducing relations, and not only ranks and individual attributes. I'm a little bit facetious and I exaggerate the point, but this is what lies behind the critique of the field and the implications that I see even now with COVID. It will be very ironic that the places where paper after paper on COVID inequities, doing the same type of practice of descriptive epidemiology that in the first place led in part into the mismanagement of the epidemic. I don't know if that, if this observation has been made before, but unfortunately, it could happen. There are major changes in public health, I would say, in Europe, and particularly, I imagine in Spain and Italy, France,
Yeah.
that probably need to take place in order to uh, 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 prevent future epidemics from causing the harm that were observed in the last year. In terms of inequalities, there is everything could have been expected. It's just magnified by an infectious disease because the time frame is shorter. So, and then there are some inequities that are specific to the COVID scenario. And for example, those that pertain to the social determinants of health, as in housing or income or nutrition or sickness benefits or
occupation conditions,
financial support, or even the effects on social security and healthcare could have been predicted because the vulnerabilities of the systems were there. Just that now they are impossible to ignore. The fact that working class populations, in particular those that are victims of the employment conditions that we call precarious, have bore the brunt, the higher rates of COVID infection or mortality. Same with neighborhoods or with working class nursing homes. Are not surprising given what we knew previously. One or more of the reasons that the goal now should not be obsessed over a gap of 1 or 2 years comparing neighborhoods and put a little bit more into the policy arena. The COVID presents itself as an occupational disease for the working class, classes in plural, especially those that are being labeled essential workers. But of course, within essential workers, we find inequalities. MDs and nurses probably get the vaccines before the gig economy workers that distribute food or that drive vehicles. And that's not usually acknowledged. So when we are talking about policy to protect essential workers, an equity lens, I think, should be applied, not only the healthcare workers or those that have the highest credentials. In addition to this situation, I think that other problems that have emerged is the problems of overcrowding and homelessness, and that could also have been expected. And here we can enter into the issue of foreclosures and evictions that should have been prevented, especially now in places where there were some measures to stop evictions and from taking place. The policies in place should protect families from being evicted and consider, as in, for example, the Spanish Constitution, housing as a as a right or as a human right as it is in the declaration. So then the fact that many working class communities didn't have sickness benefits or were not able to self-isolate and were forced to continue to work is something that uh,
Definitely.
should
It's
be
further increasing the crisis and the disease process. Yeah.
exactly, and
Mm-hmm.
that was hardly recognized in many countries as the epidemic unfolded, and
Mm-hmm.
there's a political tension
Mm.
between, I would say, the interest of capital and labor and
Yeah.
the different um, um, political forces in government were
Mm-hmm.
also fighting with oppositions with regard to the generosity of the measures. And then there was the public health community that
Yeah.
many cases did not provide the type of knowledge needed to address these
Mm.
social inequalities by focusing
Exactly.
only into clinical epi indicators, as in the case of Catalonia that I know best. So the adequacy of health and social services is another of the problems that have emerged. For example, pointing into the need of greater investment in the development of primary care.
Mm-hmm.
Just an example. Um, in terms of social services, gender policies,
Mm-hmm.
childcare,
These all are
um,
compromised. Yeah.
women, this is something that
Yeah.
also emerged as a
Mm.
need during the,
Mm.
it was already there, but these are policies that need to be put forward from a public health lens too. Childcare and um, mm, what those that in some Nordic countries are
Mm-hmm.
already developed, like the
Mm.
dual earner type model or
Mm-hmm.
regime, gender
Yeah.
regimes
Yeah.
that are egalitarian with
Mm-hmm.
uh, paternity, maternity
Mm.
leaves, for example.
Yeah.
These are all policies that in many European countries, they still are not fully
Established.
developed,
Mm.
and that um, if the EU function as a political unit, there could be an opportunity for generalizing them. Short of that, during the current situation where the EU basically serves the interest of
Mm.
German banks,
Mm.
and
Okay.
it's not really possible. So it has
Oh.
to be at the national level. I don't see it happening as some
Mm.
of the persons in our series have been
Mm.
argued, right? Even those
Mm-hmm.
that are um, believe in the European project,
Mm-hmm.
which I'm very skeptical,
Mm-hmm.
recognize that the so-called social
Mm.
mm, charter has not
Mm-hmm.
been developed, and that it's basically an economic union
Mm-hmm.
dictated by the capital of the wealthier countries. And
Mm-hmm.
I mean, we know Greece, for example, is the example of a country that has been victim to this
Mm-hmm.
arrangement. So other problems that have emerged during the COVID epidemic are the disinvestment in public health, the lack of um, uh, schools of public health know-how, and
Mm-hmm.
we talked a little bit about that with the
Mm-hmm.
critique of social epidemiology,
Mm-hmm.
and I would say all of these points to a
Consider.
series of
Mm.
policies that should be the focus of public health practitioners and researchers, rather than just showing again over and over COVID disparities.
What is your opinion in terms of the global organization and the individual countries' policy, the collaboration? So how it works, like WHO collaboration with the individual country in the European zone?
Well, I think that WHO first was criticized heavily because of its handling of the relation with China, but that's reflects the politics of many European countries with respect to China. If anything, the Chinese management of the epidemic has shown that, and I mentioned that in my own country of origin in February, that they should copy what the Chinese had done. Their control over
this pandemic,
yes, the control of the state of productive resources by building hospitals in 2 days. That was that was impressive. This type of
interventions,
it's reduces freedom, but of course, we are talking here about the public health emergency, not about the functioning of society in the long term. But some of the most immediate radical measures probably could have helped in the containment of the epidemic. Nonetheless, the narrative was we are very different from these Asian countries that are collectivist, and then the WHO was criticized for not being harsh enough on China. And previous WHO documents were, as I mentioned before, not taken seriously. Otherwise, the public health emergency preparedness would have been in place. Nonetheless, it took a while until WHO became the, I think, the source of information that everybody followed. And I think now it has regained a lot of credibility, and I think its focus on the global inequity in terms of vaccine distribution is something that's very important, and that the wealthy countries should be participating in, like Norway, for example, right? But there are many countries. Canada has done a few good things recently with regard to the global equity of vaccine distribution. So I think the message of WHO is well received, is important now. And there is a lot of so-called vaccine nationalism, and of course that's a big mistake. Not only because there is an interrelationship globally now, and but because it's a matter of the values of the global public health community,
ideologies,
and the governments, right? If it's unfortunate that was this reaction of many governments, and also of the global health community, because the position of Bill Gates, from what I read, is the one that I would have expected, but that supporters of Bill Gates and what is that study? This descriptive study, the global burden of disease,
Yeah.
had enshrined him and the theme of the global burden of disease as something of a panacea for the future of global health. And yet we've seen that when the push comes to shove, his protection of patent rights is very close to his position with regard to intellectual property, with regard to his own Microsoft products, let alone that, as I understand, DOS was developed by the US government. So I think that it's naive and misplaced to expect that a single person, in particular somebody who's the wealthiest countries on earth, should be the leader of global public health. I hope people have seen that now with the issue of the vaccines, but from a democratic perspective is a nightmare. I mean, how can that be justified democratically? Right? So in that sense, the WHO, I think, has become strengthened by this experience. And I hope that in the future it stays so, and that the world sees it as the future global Ministry of Health. Of course,
definitely.
You need. We'll see, but that's my take on it.
So, as you mentioned, Dr. Montana, that the global issues and global problems require the global solutions. And then, in your opinion, what are the two major possible solutions which are impacting the European political economy these days?
Well, that's something that other guests know better than me. If it's the political economy of health, I think that the policies of universal basic grants, the gender type policies, and regulation of the gig economy, the taxation of capital. I think that's number one, right? The tax evasion of multinational corporations, 40% of profits are not taxed, like places like Ireland, Netherlands, Andorra, in Catalonia, Monaco, Liechtenstein, or corporations should pay. There should be a crackdown on tax evasion, and there should be also a profound change into the architecture of the EU, as we were talking before, but that's doesn't seem that it's going to happen. And the strengthening of the social charter and the rights of workers all across the EU. Another big issue is the protection of immigrants, the rights of immigrants, so they are not overexploited, being second class citizens, that it happens in many European countries. I mean, people point the finger to Hungary, but really it's all over the place that they don't have the same rights, and that the fascists that in Vox in Spain and its allies on the right are increasingly blaming immigrants for the economic inequalities that are the consequence of the weak welfare state and
Mm-hmm.
dominance of the ruling classes, would say the banks, the big media, the major corporations, and the international investors. So these parties that are well funded are increasingly become unpopular by blaming immigrants. For example, in Madrid these days, which is the major center of Spain, this party, which now in Spain, I think it's number third in terms of voters,
Yeah.
signaled young, children basically that are in Spain without any parents or family members as target of their punitive policies. They want to expel them, and they complain that they are getting a small sum every month. Basically, we have unaccompanied children that are immigrants to Spain. So this is the level of normalization of a fascist discourse that we are seeing.
Yeah, yeah.
So it's not only happening with the Roma in Hungary. It's happening in many countries. It's not only France and the UK. In Spain, where there was the myth that there was no far right in Spain. In fact, it was inside the second party. Now they are strong enough to be a separate party, and they are well funded, helped by Steve Bannon, who was behind the success of President Trump. So this is a major issue, I think, the rights of immigrants, the control of the house, stopping foreclosures and evictions, housing as a human right, and the regulation of the labor market to protect workers who are in the precarious and gig economy, which is a new form of feudalism. Actually, it's not even the gig economy is it's closer to feudalism than to a capitalist enterprise, and it's growing from what I've been able to observe. So these are some of the major set of policies that I think should be at the forefront of any reformist agenda, and also the rights of peoples, right?
Definitely, the most important, yeah.
When countries have minorities that want to take control over their economy, and because the majority of their members want to, see Scotland or Catalonia or any other place, there should be enough democratic development, like in Canada, for example, as per the recent ruling with Quebec, for them to give an answer to their aspirations. It's the democratization of the continent is another major challenge, in my view.
Yeah.
So this is it.
So thank you very much, Dr. Montana. This is very insightful talk. And then if you want to add some last few words to this talk, so I will be happy to listen.
Well, thanks.
Is anything else you want to add?
No, I think, it's a great pleasure to talk to you. And
thank you.
If anybody is listening to that, so, what can I say? Support jazz. That's I would say.
Yeah, definitely.
I had to save my little bit and listen to Mike Moreno. So
No, that's definitely a great talk, and then we are very pleasure to have you. And all the information in terms of the political economy, and then the solutions with COVID-19. Your views and your experience is very valuable for this series. So thank you very much for having with us.
Thanks so much, Rosina.
Okay, sir. Thank you.
Bye-bye.
Bye.